Welcome today to our open mic webinar on the vital statistics. We're joined by Valérie Gaston. I'm going to do a quick land acknowledgement and then turn it over to her. McMaster University is the host institution for the Canadian Research Data Center Network. The university is located on the traditional territory of the Mississauga and Haudenosaunee nations and within the lands protected by the Dish with One Spoon Wampum Agreement. We'll begin the session today by giving honor and thanks to the Haudenosaunee and Anishinaabe nations, and to recognize our responsibility to respect and honor the intimate relationship Indigenous people have to this land. We can visit Native Land Digital, a space where people can learn more about the lands they inhabit, the history of those lands, and how to actively be part of a better future going forward. And without further ado, take it away, Valérie. Thank you for joining us today.
Thank you. I'm happy to be here. My name is Valérie Gaston, and I am the Chief of the Vital Statistics section at Statistics Canada. I've been in this position for many years, so I've seen many years of the evolution of the Vital Stats program, and I will present the highlights to you today of what the program is like now. So I'm going to start by sharing my screen. Can everyone see my screen?
Yes, we do, Valérie.
Okay, super. Thank you. So, I want to start by talking about generally the vital statistics system in Canada. So, it is a decentralized system of civil registration and vital statistics. So, the provinces and territories are responsible for the registration of all births, deaths, and stillbirths, as well as marriages, although we don't collect the marriages at Statistics Canada anymore. um, that occur on their within their jurisdiction. They then send the data to Statistics Canada, who is mandated for the collection, analysis, dissemination of national vital statistics um, data. So the governance of the vital statistics program is called the Vital Statistics Council for Canada, and it is comprised of a representative from each province and territory. There's actually two representatives from Quebec, because in Quebec we have the Directeur de l'État civil and also the Institut de la Statistique du Québec. So Statistics Canada actually receives data from the Institut de la Statistique du Québec, but the vital registrar is also involved. So there are actually 14 members. And this is a forum for developing common approaches for collecting vital statistics data, for sharing information between the jurisdictions, for continued discussions around issues around civil registration and vital statistics. And it is also a forum for liaising between the vital statistics registrars and federal departments beyond Statistics Canada. So, and it brings together expertise in both those areas. So, the collection of vital statistics data has seen great improvements over, I would say, the last 10 or 15 years. So, each province and territory has their own Vital Statistics Act, which determines what will be collected, what are the service standards, those sorts of things. And they have several variables that they would collect information on. So we Statistics Canada do not receive all of those variables, but we have determined a specific set of variables that we want to receive. And we have implemented, I would say, started in 2006, and we almost have every province and territory on board now. It's called a national routing system. It's more a set of standards, and it's standards in how the data will be provided and also how the data will be sent. And so it allows for multiple clients. It's a one-to-one relationship. So why I'm going into some of the detail is that you see in the first box that we have sample fields. So we have date of death, for example, with death data. We have date of death, cause of death, street address in purple, date of birth, sex, registration number. So Statistics Canada would receive date of death, cause of death, date of birth, sex, registration number. For example, that's not an exhaustive list, but we don't get the street address. Service Canada and Canada Revenue Agency, who also receive death notifications for carrying out their mandates, they do not receive the cause of death information because they have no need for it and they're not permitted to receive it, but they receive the street address because that's something that they need. So the data gets sent through the NRS. um, we receive it on uh, a daily basis. So some jurisdictions, the larger jurisdictions, would send more often, and then some of the smaller jurisdictions would do a bulk send, but maybe at the end of a week or at the end of a month. But we're constantly receiving data. So the data content on deaths, we have the date of birth, date of death, the sex and the age of the decedent. We have the usual residence postal code, which allows us to then get into subprovincial geography. We have the marital status, the birthplace of parents, locality of death, designated certifier, disposition, underlying cause, and multiple cause of death. For births and stillbirths, we have infant characteristics, date of birth, sex, weight, gestation, and we also have information on the parent. So we have the mother's characteristics and the father's characteristics. The death information that comes what we receive the information that is on the medical certificate of cause of death. So this is written out information, which then needs to be coded into. We use the ICD-10 codes. We use the International Classification of Disease, the 10th revision from the World Health Organization. So at Statistics Canada, we train the cause of death coders, and at Statistics Canada, we code the data for all jurisdictions except the big three. So BC, Ontario, and Quebec have their own cause of death coders. And so they code their own data that they then send to Statistics Canada, but Statistics Canada still trains the coders and still does the data quality um, validation before we release the data to ensure that the data are coded consistently. So we are currently using ICD-10. It was implemented in 2000 in Canada, and we use a French and an English version of the classification. We are preparing for the implementation of ICD-11, which will be completely different. ICD-10 now has a 4-character code. ICD-11 can go up to 14 characters, and they've completely revamped how the classification is going to work. So there's a lot of work going on in the development of how this is going to be implemented, how we need to develop training materials, we need to develop comparabilities to make sure that any changes we see, is it part of the classification or is it really changes in the data? I anticipate that the implementation for ICD-11 would not occur before 2029, 2030. There's a lot of work that needs to be done. So I spent a bit of time talking about the NRS at the beginning, and what I wanted to kind of why I did that was because it's allowed for many improvements with the vital statistics data. So first of all, receiving data electronically and in a common data standard has greatly reduced the amount of time that is necessary for us to validate the data and to process it and to disseminate it. So this was seen during COVID, where we used to release on an annual basis, and then we had to turn around and release on a monthly basis. And that would not have been possible without receiving those data electronically. Now, the next big improvement, I would say, that's happening with data collection is the EDR, what we call electronic death registration. So the provinces and territories for death data, and I've focused on death data because the birth data are fairly timely as it is. So the death data, when a death occurs, there are two portions to it. So there is the portion that gets completed by the funeral home, which is usually with the next of kin. Um, and that information gets sent to the vital statistics registrar. There is also a portion that is completed by the medical certifier, so it could be a physician in a hospital, a nurse practitioner, or if it was a sudden and unexpected death, it would be a coroner or a medical examiner. So, what is happening now is that we have some of these processes which were largely paper based, and then they had to be data captured at the province territory level or at StatCan. So now we're getting into electronic processes. So where I have here full EDR provinces are provinces where both the funeral homes and the medical certifiers are doing all the registration, all their paperwork electronically. So it's not paperwork then, I guess. But and then the partial EDR is where the funeral homes use an electronic system to transmit the information, but the medical certificate of cause of death is still done in paper form. So what you can see is that for full EDR provinces, so who those provinces, and there's only a few of them right now. There's only three. Um, so they have uh, both the medical certificate of cause of death and the funeral homes using electronic um, mode of transmissions. Then we at StatCan receive the information within 8 days of the event occurring. So this is a huge improvement on timeliness for the provinces and territories that use the funeral homes for that have electronic registration and then the paper for the medical certificate of cause of death. We're still seeing 19 days. So within, on average, 19 days, we will have received the first notification that this death occurred. And then for the provinces that are paper based, we're looking at over 3 months. So this is right now the a big focus of our work, and we're working with Service Canada on this to move the provinces to an electronic process so that we can speed up the notification. So, from a statistical point of view, um, you can see the importance when we're looking at the importance of having death notifications with pandemics or any other health um, crisis. And from, Service Canada or CRA, it's a little bit different. It's more of an administrative use of the data, but the sooner they get the notification, the better it is for them as well for either starting payments or canceling payments, etc. Now, the downside of getting data faster also means that there is a greater chance of having incomplete data. So, what we've used here is the dark blue line is the initial release. So, for death data, we usually release the annual file either in November or early December. So, 11 months after the end of the reference period. But we will have stopped collecting the information. We have to close our file maybe in July to meet that deadline. So we've used cancer to kind of represent all the natural deaths. So deaths that aren't typically investigated by coroners or medical examiners. So you can see that from the initial release to the lighter blue line, which is 3 years after the update, it's pretty complete. So our death and causes of death at the time we release for natural causes, I would say is I don't have a percentage here, but you could probably calculate that quickly, but it's up in the high 90s. If we look at the types of deaths that usually take longer to investigate. So they would initially come in as R99. So you see at the top, R99 is the ill-defined and unknown cause. So you see that at the time we initially released the data, we have 6,686 of those, and 3 years later, we've cut it in about half. So that means that half of those records get redistributed into accident, suicide, and homicides. So, this is the tricky part because accidents, when we're looking at opioids or when we're looking at suicides, these are the data that we mostly most want to know and have very up to date data. So, but we see here that it's taking at least 3 years to get all that information. There will always be a remainder of causes that are unknown because sometimes it's just not possible to determine how the person died. But you also see that a lot of those get classified into accidents and suicides and homicides. So we have different data products depending on your needs. So we have the monthly provisional data, and it covers deaths and grouped causes of death. It enables more timely reporting. We release data monthly, but we have weekly counts. And we are currently revising our excess mortality indicator, but that is an indicator as well that will help us kind of feel what's going on. And if there's something that's, rising, then we can look into in more detail. The provisional data, the completeness does vary by jurisdiction. And if you recall the slide that I was showing with the EDR and the partial EDR, so obviously the full EDR provinces will have more complete data. The annual preliminary data. So we release the births and stillbirths in September, end of September, so 9 months after the end of the collection period. And then the deaths and causes of death, usually 11 months or early December after the end of the uh, collection period. We do revise the data on a yearly basis, and we're still trying to determine when do we stop getting updates to the data. So we're not quite on that calendar yet. So we're just revising constantly at this point. So here I just wanted to give everyone some information on our most recent releases, and I can share these slides after, and you could actually the links would bring you to the most recent releases, which then can link back to the earlier releases. So for births, there are 11 coder tables that are released. And we also work with our colleagues in demography who release information on fertility indicators. And then they've also created the Baby Names Observatory. So all that information is available here. This is an example of their dashboard, their interactive dashboard that they've created. So we do get many questions on fertility. So hopefully that gives you a nice overview to answer some of the most common questions on fertility. For the stillbirths, we typically release them at the same time as births, but sometimes, if for whatever reason we can't, we delay it a little bit. It includes 4 tables, and then you have a link here to the different tables. As far as deaths go, there are 39 coder tables with our deaths releases, and many focus on the individual chapters for the ICD, the classification, the ICD-10 classification. So if people are looking for very specific diseases, there are about 8,000 or so 8,000 things you can die of in Canada. You can go to the individual chapters, or you can go into the leading causes, which will give you the sort of the main ones. We also have mortality rates and life expectancy, and I'll see if we get to it later before I say that. So we also have a couple interactive dashboards for selective causes of death, which make the information a little bit easier to digest because um, the tables that we have, which I believe they've been around since before I joined Vital Statistics, and I think it was just a progression of what was a paper table. They made it into um, an electronic table. I think with the tools that are available to us now, we could work on developing more of these visualization tools and more interactive tools. This is an example of the provisional deaths in dashboard that we have. So this, again, we started with during the COVID pandemic. So you can see where the peaks are, where we had high excess mortality, which did mirror the waves of the COVID pandemic. So these are again updated and give you a completely different view of the mortality data in Canada. And then I just wanted to, I popped this in here just to see, despite the limitations of how sometimes difficult it is to find the data on the StatCan website, and the tables being not as user friendly as I think we could hope for, that many of the tables that are viewed it for our center for our branch are vital statistics data. So they're very popular. The leading causes of death are the most popular, but the mortality rates, the age specific mortality rates, life expectancy, which is again done by demography but uses our data. So there's a lot of the green, the one in green is the one that's not part of our part of the top 10. It's not, doesn't fall under vital statistics. So there are a lot of key indicators that use vital statistics data. So obviously the population of Canada doesn't just use births and deaths, but it's key components. They are key components of it. So the population estimates in turn are used to produce other statutory requirements, including transfer payments. So other key indicators that use the vital statistics data, so we have cancer survival estimates, infant mortality rates. They're used also in many data integration projects and studies. So part of that is that deaths especially end up being the ultimate health outcome. So it allows us to then um, gain broader insight into the data and increase the disaggregation to look at specific groups. So one of the other data sets that we have in the vital statistics section is the Canadian Coroner and Medical Examiner database. So this is essentially a subset of the vital statistics data, death data, and it is the data that the deaths that are investigated by coroners and medical examiners. So we get a separate feed of those, and the CC Med, what the greatest advantage of the CC Med is that it allows us to get more detail around the circumstances that led to these deaths. So for example, the snowmobile fatalities, we have an infographic, and um, it is not possible with an ICD-10 code to pull out to distinguish between snowmobiles and ATV deaths. So the risk factors can be different. Obviously, the conditions are different. So we're able to, with the CC Med, to look into more details about the snowmobile fatalities. So we can look at things such as were um, safety precautions used. We can find out more about the weather conditions, about whether or not alcohol and drugs were at play. So it's a key data set to come and provide, like, paint the picture. Now the CC, the coroners and medical examiners, they investigate about 15 to 20% of all deaths. And currently we have data, and since we now have data for 2025 as well, but we contain data on over 500,000 cases from 12 jurisdictions. We're still missing data from Manitoba. The trickier part with the CCMed data and using the CCMed data is that most of the information is in text format, so it's not as easy to analyze and to interpret. I'm not going to go through that. Data uses. So we talked about it a little bit before, or I talked about it a little bit before, that the health indicators that are using vital statistics data, we have life expectancy, excess mortality, age and sex mortality rates, leading causes of death. We can look at specific things like infant morbidity and mortality rates, preterm births, congenital anomalies, low birth weight. The population estimates, which are then used for the generation of 30 plus statutory requirements. And then also data integration is a huge component, I should say, the vital statistics, especially the death data, is a huge component. Um, We've also been using the birth data, and they call it the mother-centric file, where they've actually linked the birth data to itself so that they, instead of being the child as a unit of analysis, it's actually the mother. So then they've combined all that data, which is also a really interesting way to look at birth data and especially looking at from the point of view of the mother. Future developments. So I talked about this, the electronic death registration, which is um, really exciting for us. We're working with the jurisdictions to implement the medical certificate of cause of death. Just some improvements from our perspective. First of all, if you don't have to read physicians' writing, it takes a lot of the guesswork away. It takes a lot of the possible error that happens at data capture, takes that away. The whole process around receiving images, loading images, bringing them, uploading them into the system, it saves us. We've estimated about a month of like one FTE, 1 month of one FTE per province per year. So it's huge. Um, so obviously, it would improve the timeliness for surveillance, and it would also allow us to put some edits at the source. The implementation of ICD-11 is another big project and another big change that's happening. So we're working on training tools. We're working on also being able to explain the changes to users. We're planning for a comparability study and also the training of the coders. So, some of the other projects that are kind of related as well is we're looking at machine learning and natural language processing to classify the text data that comes into the CC Med. So, it would be easier to, if we're looking at, let's say, opioids data and we want to get specific drugs, then we can do term searches. We're looking also at increased data integration. I didn't talk much about it, but we also receive data on medical assistance in dying. Health Canada is um, the designated recipient for those data, but we do receive them as well, and they are in the RDC. So looking at linkages using those data, we want to add historical data prior to 1974. Right now, we know that the 1974 to 2024 data are consistent and use the same record layout. So we'd like to go further and add more years. And as I was mentioning, also have more data visualization tools. A couple other projects I didn't talk about, but I'll just mention here. When I was referring to the slides on the causes of death and updating causes of death, so we have a couple of projects that we're looking into that were feasibility to improve the interpretation of that R99 group at the time where we release the data. So we're looking at how those evolve over time to see if we can estimate not by cause, but by category. So will we be able to say with, let's say, for example, the release of 2025 um, or I should say 2024 death data, would we be able to say of the percentage of R99s that we have, um, 20% will end up being opioids, um, 10% will be suicides, and I'm just making data up, but that we're looking into that whether or not we can predict those. We have also implemented uh, a fourth character on those R99 so that we can say one. We haven't received an image, so we can't say anything. We don't know what the cause of death is, or that we did receive the medical certificate of cause of death and it says pending investigation, so we know that will change. And then we have a third code, which is, it's unknown. It's finalized as unknown. The third, project we're doing is with using the information from the CC Med, because we do receive the information that was entered on the medical certificate of cause of death. And can we code that? And how does that compare to the information we eventually get from the vital registrar? It should match. But then that would help us determine if we can use the data from the CC Med to kind of fill that hole more quickly or be more timely. And can we then use some of the detail that's in the CC Med to then be more precise with the coding? So those are the main projects that I would say we're looking now as far as improving the data. And I think that was my last slide. So I'm happy to answer any questions.
Okay, thank you very much, Valerie. So now is the Q&A section. So everyone's got the ability to unmute and camera off. There's a lot of us, so maybe I would ask if you can to use your hands if you've got questions. Oh, there's one popped up in the chat there. So Chris asks, does StatCan share death data with ChiHi to link with things like the discharge abstracts?
So yes, so we do link to dad, and there is, and this isn't my my area of expertise. They do link the death data to the dad, and I think to knackers and omers consistently. And then those data, I think there's an agreement for those data to go back to ChiHi as well.
Um, so an easy question. Philippe asks, do stillbirths contribute to the fertility rate calculations?
No.
No. And then Arju's got a little bit harder question. The daily birth data include a postal code. Can you specify whether this is postal code of mother's residence, location of birth, or the location of the hospital?
It's the mother's residence.
Mother's residence. Okay. I'm going to ask a little tougher question. So with the ICD-11 implementation, one of the things that I remember when we switched from ICD-9 to 10 was that it was really kind of a bit of a Wild West in terms of mapping 9s to 10s. Is there a plan to, as you're developing this, kind of create a mapping that will let us do more longitudinal analyses and then share that through the RDC program and make sure that everyone's kind of working from the same sheet?
Yeah, and that is a good question. And the so right now we are looking into and the benefit that we have is we have the ability to be contributing on an international um, working group for the development. Well, we have an international um, automated cause of death coding system. So the decision tables are the same, and then we can just have like the front end, the language is different. So we're involved with that. So our mortality classification specialist is actually looking at things in ICD-11 and coding them now in 10, and where do they end up? And so we are working on that. So we will need to, because the way what I've seen of ICD-11 is that unless you are completely immersed in it, it would be really difficult for users to do that sort of back coding.
I see Zara, thank you. I see Zara's turned his camera on. Do you want to ask a question, Zara? Oh, no. Okay, so we've got a couple more in the chat. So a couple from Arju on provenance. Where do you receive the birth and death data from? From the registration office or hospitals?
So both.
Both.
So just as I was describing that for a death registration, you have the funeral home and the medical certifier. It's the same thing for the birth registration. So you would have the parent who completes the registration of birth, and then you would have the birth attendant, whether it's um, what's the word I'm looking for? Not a birth doula, but
Midwife?
yes, thank you. A midwife, thank you, or a hospital. So they would also send in the live birth notification. Both go to the provincial territorial registrar, and when they have both pieces, then they can say, yes, this birth occurred.
An update on the postal code. If it's an indigenous community, do you use the community postal code? I don't know enough to.
Yeah, so that is a good question. So we use the postal code as it is provided to us. So if it doesn't fail an edit, that's what goes on the file. So for that question, I'm not sure. It all depends what the mother put in as her
That's her
postal
postal
code.
code.
Yeah.
Okay. So then there's a question from Philippe. Why is cause of death important to know about? I think well that would depend on the research question, but for old people with chronic diseases, there could be a vague concept. Is there multiple causes of death that can be recorded?
Yes, absolutely. So everything that is on the medical certificate of cause of death is captured and coded. The rules for determining the underlying cause of death, which is the disease or train of events that started the progression that led to the person dying, is what we tabulate on, and that's called the underlying cause of death. However, we do have the multiple cause data, and it's kind of a separate file, um, but that's linkable, right? So you can absolutely look at all those conditions, and there can be up to, I think, 20 or so conditions that can be listed.
Paul asks, the timelines for the data processing are interesting. What about the releases into the RDC? I think Paul's saying the most recent file is 2021.
There's actually a 2023. I know that the 2023 data are in, they were in as of last week, but you're right. We released it in December, early December, so it did take a bit of time to make its way. So um, we also released an update to the 2017 to 2022 data in February. So that's probably going to be released into the RDCs, hopefully soon, but maybe next month. If we look at, I think it takes about a 3 month.
Yeah, no, I'm just looking. Last week, Tuesday, I got the notification that 2023 is in. So Paul, you can follow up with me via email and we can get those data into your project. I think that's the best that's the best way to do that, I think. Um, okay. Is the multiple cause of death data available in the RDC uh, vital stats database?
So I think so, but let me check on that. I don't see why it wouldn't be.
Okay. Um, And yes, Arju, we will have the video will be up on our YouTube channel. We try to get it posted pretty quick, so we should be able to find that on our YouTube channel next week or the week after. If you just search CRDCN, that's our channel. So there's a question from Parvinder about data access. I'm Parvinder, I'm assuming you work for the municipality. Is that if that's correct, we can connect about how you can access the data. And Melanie asks if the CC Med will be available in Manitoba soon. You said it wasn't available, but there wasn't really a timeline
Yes.
if it's coming.
Well, I don't know. We've been working on it for years. So I think part of it is uh, legal folks question about, can we share the data and all that? So it's been hanging around for a while, this one, so I don't have a deadline for that.
All right. That was excellent. Lots of really good questions and an excellent. Are the hospital births of undocumented mothers included in vital stats?
Yes, um, they
Probably not
are.
tagged as such, though.
What's that?
Probably not tagged as such, though.
No, and we don't. So um, if we know that the mother is not a resident of Canada. So our data we release for residents of Canada. So we would likely receive the information, but then we have like one table where I think we may have by place of occurrence, place of no, hang on, I'm telling you 2 different things. We do have that table, so you can see how many, let's say, births, and it happens a lot in Quebec, Ontario. So the border in Ottawa, there's a lot of mothers in Quebec who will give birth in Ontario. So we release by place of residence of the mother, but there is a table where you'll see how many were born in Ontario, and then you see how they get put back into their province of residence. If the mother is not a resident, then we don't include them in the data we release.
Okay. And then there's a question, which newborns might be missing when the birth data are linked to the administrative data sets like DAD? I don't know that the birth data are linked to DAD, are they? I think it's just the death data, but I could be wrong about that.
Um, that is a good question. I'm not sure. And whichever would be missing, I mean, I'm trying to think. We used to, at some point, the birth data and the death data were linked because we wanted to get at the infant deaths. And then there was a problem with I think some children who died very early, the births may not be registered, so then you were missing some of those births in the birth data, but I'm not sure if that's, I you know, my assumption is that every birth that occurs in Canada is registered.
So Bekyang, you asked about the CAN checks. That's actually Health Stats Division, which is not Valerie's division. But if you want to send me an email, I can reach out to somebody at Health Stats and we can figure out the question. Okay, so Paul's commented again, it doesn't seem the 2022 data are available in the RDCs. Which would be strange if the 2023 are available. So maybe I think there was something else you were going to look into about the RDC file. Oh, the multiple causes of death.
Yes.
That might be something else to look into at the same time for
Okay.
us, which we would appreciate. Okay, I think I have answered everyone's question. If you have a hanging question that was in the chat, feel free to put it back in if I didn't get to it. There was a gentleman who popped his camera on. I don't know if you had a question, but you're welcome to come back. I don't want to take up all the airtime. All right. Well, thank you, Valerie, for an excellent presentation. We'll just going once on questions, going twice, sold. And I think Valerie's email was on the slides. So if you have anything that occurs to you in the middle of the night, you can always send an email. Oh, there is one more question. Chris is asking if divorces were counted as vital stats at one time. I think they're not collected by StatCan anymore.
No, they were, that information came from Justice Canada, but they were released as part of our program. But in 2010, I think the marriages and divorces programs were canceled.
All right. Well, thank you very much, and I hope everyone has a lovely rest of their day.
Thank you. It was
See you next
lovely
time.
meeting you all.
Bye bye.
Bye-bye.